I'd also like to do the traditional welcome to country, that the College of Surgeons acknowledges the traditional owners of the country throughout Australia. We recognise their continuing connection to the land, waters, and to the community, and we pay our respects to them and their cultures and to their elders, past, present, and emerging. Just some housekeeping. Everyone would just like to consider, if there's any questions, to just type some questions in the chat section. In the bottom, we'll collate those and we'll save them to the end for all of the relevant speakers. So I'd like to introduce our first speaker, which will be Danny Agnola from the Australian Digital Health Agency. Danny has had over 14 years in the community pharmacy industry, having completed his studies at the James Cook University. He worked at the Pharmacy Guild of Australia in the Queensland branch as a professional service pharmacist, where he assisted in the provision of the intern training program, implementation of professional standards, and integrating new services into community pharmacy. And since 2017, Danny has been employed with the Australian Digital Health Agency, where he was a national My Health Record primary care educator before taking on the role of managing the Clinical Peaks Partnership team. He has a passion for digital health and the benefits it can have for all Australian healthcare providers and their patients. So I'd like to welcome Danny, and over to you for your presentation.
Thanks very much, Mark. I'll just quickly share my screen and start the presentation. So the topic I'll be talking about this evening will be around electronic prescriptions, which I think is a really fascinating subject, and I think it's very long overdue in the Australian healthcare sector. I've only got 10 minutes, so I'll be very quick. But what I'll initially like to do is just set the scene. For people who know the Australian Digital Health Agency, you might see us as the My Health Record agency, but we do have a number of pillars of where we're working. And electronic prescribing fits within the fourth pillar there under medicine safety. So the aim or the goal of electronic prescribing is to ensure that there's digitally enabled paper-free options for medication management. So I'll go through the main key benefits in a little while, but we really want to support consumer safety and patient safety by reducing the risk of things like transcription errors, and also assist our healthcare providers in reducing the unnecessary paperwork that sort of comes with the normal sort of paper prescriptions. So looking at the roadmap, so everyone's aware of the paper prescriptions, which we've had for many numbers of years, and probably over the last 12 years or so, you've probably noticed the barcode on some of those prescriptions, which is ETP, electronic transfer prescriptions. That is completely different to electronic prescriptions, but we are using some of that infrastructure for electronic prescriptions. So at the moment, with COVID and all those sorts of things, the Department of Health have interim arrangements for prescriptions in place. So this is more around image-based prescribing, or what the department called prescriptions via telehealth. And it is a Department of Health-led initiative. So the agency unfortunately doesn't have a lot of role to play in that. But what I'll be talking about is the next two. So, so from May 30, I know we're past that, we've got the rollout of, or the progressive rollout of the token model of electronic prescribing, which I'll touch upon later. I say progressive rollout because we are initiating these in areas called communities of interest. So the main reason for this is so that we can ensure that the technical requirements are working properly, the interaction with Medicare and all those sorts of things, and any sort of issues are ironed out before we go on to a larger national rollout. And we want to make sure that while that's taking place, we're getting, especially pharmacies, ready for the implementation and the rollout of electronic prescribing across the country, but also for our prescribers as well, GPs, specialists, etc. And then from later on this year, not only will we have the token model, but we'll also have a model called the active script list, which I'll touch upon once again in a little bit. I think that will be a great option for people, especially when they have multiple medications and multiple comorbidities, so that their medications can be properly managed. All throughout this roadmap, there is still going to be the option for paper prescriptions for the patients themselves. So what are electronic prescriptions? So as I said, they are an alternative to the option of a paper prescription. So previously we only had the paper prescription as that option, which was always signed by a doctor. But as of October 31st last year, there was new legislation passed, at least on a Commonwealth level, for electronic prescriptions. Those legislations have gone through state and territory governments as well. We're still waiting on a couple to formally cover those legislations off, but that should be happening anytime soon. And once again, I'd just like to point out that electronic prescriptions they're not going to be mandatory. There's always going to have, the paper prescription there for the patient, and also for the prescriber who's prescribing that medication if they don't want to or are unfamiliar with using electronic prescriptions themselves. So briefly, why are they important? I think we can all come up with ideas around why electronic prescriptions can be important, not just for us as providers, but also for our patients. It's going to provide greater choice for our patients, but it also maintains the privacy and the integrity of the personal information for that patient. And we do have more information on our website around, privacy and how personal information is stored or is sort of sent via an electronic prescription. No better time than COVID at the moment, because it provides an opportunity to protect those community members and providers from exposure to infectious diseases. Not just COVID as an example, but over the last few years we've experienced a number of natural disasters ranging from bushfires and floods and those sorts of things, where electronic prescriptions could have come in very handy. It removes the need for handling and storing a physical paper prescription. So, instead of having to fax a script to a pharmacy to dispense, we can send that electronically to the patient to then get it dispensed. Improving the efficiency in prescribing and dispensing medications, and hopefully reducing prescribing and dispensing errors. And tonight's all about telehealth as well. So it's in support of other digital health services such as telehealth, to ensure that continuity of care for the patients is actually there. So I've mentioned a couple of examples of what an electronic prescription will look like. Obviously in the hospital setting, it's going to be a little bit different. That's what's called a direct model. I'm going to be talking about generally something you'll see out in the community, in private practice, or from a GP, for example. So the first one is a token model, and this is the one that will be progressively available from the end of May. So we do have some communities of interest sites where real electronic prescriptions are being prescribed and dispensed currently. So I think that's very exciting. So what a token is just like an airplane ticket. So it's a unique QR code that is sent to the patient either via an SMS or an email, and hopefully not in the too distant future via things like apps and that sort of thing. So the QR code itself is not the legal prescription, but once it's scanned in the pharmacy, it's used as a key to unlock that legal prescription from what's called the PDS, or the prescription delivery service. Okay, so the QR code acts basically like a key to unlock the actual legal prescription from the delivery service itself. I've mentioned the communities of interest. So we're working very closely with software vendors, with organisations, and with providers both in the GP space currently. We'll obviously be moving just from GPs, but in pharmacy, to ensure that all the functionalities are running correctly, that the links to Medicare are working correctly, and that any issues are sort of ironed out before we move to that to the next level and ultimately national rollout. The next one there is the active script list, which we're hoping to have towards the end of 2020. So it is further functionality of electronic prescribing. So under this model, once the patient gives certain identification to a pharmacist, for instance, that pharmacist will then be able to dispense the medication down from the active script list. So it's basically going to be a list of all those prescriptions, active prescriptions that patient has, and then the pharmacist will be able to dispense down from that list. You know, there's multiple benefits coming from the active script list, especially for those patients who do have a lot of different medications where, you know, managing a number of different tokens might be difficult. And will also be, you know, especially beneficial for those patients who are vulnerable or, you know, don't have a lot of health literacy and those sorts of things. So I can see it being extremely beneficial moving from the end of this year and into next year. So just because this webinar is basically a telehealth and electronic prescribing, I thought I'd just do a very simple case study around how we can embed electronic prescribing in things like telehealth. So if you look at James, we've probably seen a lot of Jameses in our times. 72-year-old gentleman who has, you know, a couple of different chronic illnesses, and he's also not physically active. He doesn't live with anyone. He doesn't own a car, so getting things is obviously quite difficult for him. But he still needs that regular supply of medications. So he goes to the doctor, he doesn't go to the doctor. He gets a telehealth consult from the doctor. The doctor discusses the different methods of prescriptions, including the new electronic prescription, and the doctor then issues the electronic prescription to James via an SMS or email. James receives that message either as an SMS or email, and he's then able to pass it on to the pharmacist. Okay, so the pharmacist then receives that token, and depending on the pharmacy software, that's then queued in that software and dispensed as per a normal script in that pharmacy. Depending on the pharmacy, they could also deliver that medication for James, or alternatively get some other way of getting that medication to him. So it's a very simple case study, but I think it highlights some of the importance of electronic prescribing and how patients can benefit moving forward. We've also developed a number of different consumer communications and resources. This isn't available just yet for consumers, because we want to make sure that our providers are aware, and for those in particular GP and pharmacy work providers are not only aware but actually have implemented it and know what they're doing with electronic prescriptions and electronic prescribing. So the consumer campaign will be coming, and it won't be too far away. In the meantime, however, we do have a number of resources, especially on our digitalhealth.gov.au website. We've got a web page which has links for prescribers and dispensers. There's a number of FAQs. We're running a lot of different webinars moving forward. We've got some fact sheets, and we'll also have some e-learning modules coming up shortly as well. For prescriptions via telehealth as well as electronic prescribing, the Department of Health also have a number of resources there. So that's it from me. Thanks, Mark.
Terrific. Thanks very much, Danny. And obviously an enormous amount of work that's gone into that, and still to come to that, but obviously the way of the future. So I'd like to now introduce Rocky Ruperto from Avant to give his talk. It's going to be telehealth implications on practice. Rocky's bio is that he's the legal and policy officer for Avant. He advocates for changes to health-related legislation, regulation and policy with the aim of making a positive difference to the practice of medicine and the Australian healthcare system. He also provides support to doctors by developing a range of medical, legal, educational content and sharing information that encourages doctors to reduce their medical legal risk and improve patient safety and quality. Certainly, obviously, been something that I think all surgeons have had to grapple with over the last 2 or 3 months. So, Rocky, I'll hand over to you, and thanks for enlightening us on this aspect.
Thank you, Mark. I'm just sharing my screen now, so you should be able to see that. Thank you for having me tonight. As Mark said, I am from Avant and I work in the team where also our claims coders work. So at Avant, we code all the claims and complaints that we receive over the years. And so for tonight's presentation, what I thought I'd do is ask them actually to have a look and to aggregate those claims, specifically in telehealth, to kind of give us an idea of where we are seeing claims related to telehealth. And then, as Mark said, we work in advocacy, so we use that data to inform our advocacy positions, but we also use it to create these, to create our educational content. So whether it be fact sheets or podcasts or for events like tonight, so that we can let doctors know what particular areas they can concentrate on to help mitigate their risks, so their medico-legal risks. So you can see here that the graph on the left are our telehealth claims from the past 3 financial years. And telehealth has, created a relatively small blip on the radar. Only 1% of our claims over the last 3 financial years have related to telehealth in some way. So what we've done during the COVID-19 time, certainly since the end of February, we've tried to identify our claims that relate specifically to COVID-19. So then I looked at those claims and then tried to decide how many of those related to telehealth. And you can see that there's a much larger piece of the pie there that relates to telehealth. And obviously that's due to, as well, a lot more people using telehealth. But I think the coronavirus was the advent of telehealth really in the proportions that we've probably tried to get to for a long time now. So I think I read a stat recently that Medicare has been charged over 12 million telehealth consultations so far. So it's seen this huge rapid expansion. And so while I expect over time that 10% chunk to be reduced, I don't think we'll ever see it get down to 1%, and it may even increase. So what I asked our coders and researchers to do then was to give me an idea of what other issues surround telehealth. And so when we code a claim, we also not only look at the primary causes, but the secondary and tertiary ones. And you can see below there that they're the top 3 combinations. So telehealth and medication issues, telehealth and consent issues, and telehealth and a procedural or surgical issue. Now, those don't change too much from regular face-to-face consultations, but I thought I'd look at the claims and kind of give you some insights about what these things mean within the telehealth realm and how you can prevent doing some of those things so you don't see a claim or a complaint in the future. So on the next slide is telehealth and the medication issue. And so I'll pick up from what Danny was talking about. He mentioned the image-based prescribing, which is the interim measure which the Department of Health put in so that doctors could offer a more full and complete telehealth service before electronic prescribing has really come out, even though it has been fast-tracked. So image-based prescriptions in Victoria specifically, because a credit to our federal system. Every state has different laws about these, so I've tailored it to Victoria tonight. Image-based prescriptions are where you formulate and you create the prescription and then you send it electronically to the pharmacist. Now, we have seen doctors receive some complaints in this area so far, and it's not only complaints by patients, but also by pharmacists notifying AHPRA if they haven't conducted this process correctly. So in Victoria, only Schedule 4 drugs can be prescribed this way, and it doesn't include any drugs of dependence. These interim arrangements are in place until the 6th of October 2020, unless they're recorded earlier or unless they're extended. And that date's important because it doesn't exactly line up to the Medicare telehealth items, which expire on the 30th of September. And it doesn't align to other states either. Some finish on the 30th of September, some finish, like here in New South Wales, they finish next year. Now, what doctors are required to do is email, fax or SMS these prescriptions directly to the pharmacist. They shouldn't be going to the patient, and that's the main area of confusion we've seen. So if you're using an image-based prescription, you send it straight to the patient's pharmacist, which will require you to find out who their pharmacist is and where they'll be attending. You are required to sign by hand these prescriptions and keep them for 2 years as well for audit purposes. And you must record, probably in the medical record, that it has been transmitted under Public Health Emergency Order number 4. Now, the good thing for Victorians is that electronic prescribing, as Denny was speaking about, is rolling out in Victoria first. It's already started there in Victoria. The laws are in place to support electronic prescribing, and that way you won't have to worry about any of these things listed above. But it is a progressive rollout, so not everybody is equipped to use it at the moment, but you're certainly doing better than other states which don't even have the legislation at the moment to support it entirely, especially around some of those trickier drugs like the Schedule 4Ds and Schedule 8s. So the next one we're going to talk about is telehealth and consent. So consent's always an issue, whether it be face-to-face or over telehealth. And I'm not going to talk about the shared decision-making process that you go through with your patient to decide on the diagnosis and the treatment plan, but rather the things that are specific to telehealth. So you need to get consent for the consultation to actually be conducted by telehealth. And that might seem obvious and it might seem implicit in the patient's actions. They're probably the ones who, book or make the or get the referral and seek you out. But you really should be equipping them to make an informed decision about whether or not they do want to go down the telehealth path. And, during this coronavirus time, maybe there wasn't a lot of choice otherwise for them. But if, if things go as well as they have been and post-September, we really integrate this into our permanent practices, then you will be at a point where you'll need to discuss with your patients the risks and benefits of telehealth. And so that mainly includes some of its limitations, or whether or not, which I suspect most of you will have to as surgeons, adopt a mixture of telehealth and seeing the patient face-to-face. Now, you will also have to gain their informed financial consent. As you know, Medicare, there are Medicare items that are available to surgeons. And, a confusing thing here was when they first came out, you had to bulk bill, then you didn't have to bulk bill, and it just went a little bit back and forth. But for the longest time now, since April, you haven't had to bulk bill those, which has been really good, especially compared to the GPs, which do have to bulk bill a certain segment of patients. But you do have to let your patients know whether or not they will be bulk billed, the fact that there could be options out there for them to be bulk billed, and also if they will have any out-of-pocket expenses. Now, you can delegate this responsibility, and you might work that into your practice processes to have the practice staff speak about billing and the patient's options, but ultimately it is your responsibility. And these consents can be verbal, but at the very least, you must document that they happened, especially with regards to Medicare. the Department of Health has made special arrangements for the assignments of benefits to happen verbally, so long as you note it in the patient's record. But after the specific COVID numbers are done away with, and when you are implementing this in your practice on a full-time or a more regular basis, you should make sure that you have that consent. So the last thing I want to speak about, which is probably the most relevant to you as surgeons, is telehealth with a combination of a procedural or a surgical issue. And the question that we're asked time and time again is, does the patient require a face-to-face consultation, and how are these conducted over telehealth? During the peak of our coronavirus time, this was really difficult, but as we are going back to a sense of normality and you might be seeing more patients, you may be able to decide, and you have the luxury of deciding whether or not you will call a patient into your rooms to have that face-to-face consultation. So when I went through the claims related to this area, it seemed to be relevant to both the pre-operative and the post-operative times. And there was this underlying theme of patients feeling safe and feeling secure in a doctor's care. So, something happened, and inevitably we hear about it after something has gone wrong in the operation. But that's when the allegations come out about, well, during the pre-op, which is really the consent, things weren't discussed about complications, and there weren't discussions about how, as a patient, if one of those complications did arise, they would deal with it and how that would affect their lives. So their expectations weren't managed at that time. And then after the complications, it comes out afterwards. But also in the post-procedure world, patients saying that their surgeons really didn't have enough time for them. They didn't get that support that they needed over telehealth. So that is about concentrating on your communication style, and also deciding and really thinking about your patient selection and who you will agree to see via telehealth if face-to-face is an option. Now, during this time, where we are doing a lot more face-to-face and that isn't an option, the Department of Health has said that you do have to offer some kind of face-to-face consultation, or it should be arranged somewhere local to the patient, and it has to be arranged if it's necessary, especially if you are billing one of the item numbers. The item numbers stand individually and they are entire clinical services. So if you are having a telehealth consultation with a patient and you get halfway through it and you decide, oh, hang on a sec, I need them to come in and see me. Or if that's not possible, I need them to go and see a colleague, whether it be another surgeon or a GP, to do some kind of test which is closer to them. That is seen and considered as the continuation of the same item number. So you do have to work out your processes and practices with your colleague about how you bill and how you charge, but only one item number can be charged there. You also have to think about, especially in this COVID time up until September, telehealth has traditionally been video conference. But during coronavirus, and given that we all had to make this really quick switch, they did allow for telephone consultations to occur where there's only an audio link but no video link. And they have specific item numbers. So if you are using telephone only, you should be using those specific item numbers when you charge Medicare. Now, they are your only two options. We have also seen, and the department has come out strong about this, the first trickles of compliance action, and some of them have been around doctors charging Medicare when they don't use either video conference or telephone. They're only using chat boxes or apps or emails and things like that. So if you are charging a Medicare item number, you have to make sure that it's video conference or telephone during this COVID time before the 30th of September. Now, I'm not sure if they're going to continue with the telephone item numbers after the 30th of September, but it's always been the department's preference that you use video conference. And while they've made telephone available, they have said that video conference should be used and should be your first preference. So my recommendation to doctors is always, if you are going to use telephone, just put a quick note in the patient record as to why video conference wasn't available. And it could be something as easy as, you didn't have the right internet bandwidth, or your patient wasn't comfortable using it, especially during this time when we're all getting used to telehealth and moving on to these platforms. Now, I think there's advantages, especially for you as surgeons, to use video conference, and that is that you get to see the patient. But also for the patients, I think it forces them to really, put themselves into a quiet room, set up, and get into the headspace that this is a medical consultation and this is not just a chat to their friend on the phone and they could be doing something else. Because we have heard from doctors that patients, when they are doing these telephone consultations, are at the shops, or you can tell that they're driving or they're out in the garden, and it doesn't put them in the frame of mind that this is, a serious medical consultation. And that will then affect those pre and post procedure conversations that I was talking about. And we already know that when people are either hearing bad news or taking on really technical information, it might take them a few goes to understand that, especially when you deliver bad news, like the outcome of a surgery that maybe didn't go to plan. They don't register a lot of the things that come after that bad news. So if they also have added distractions of not actually being in front of you or actually seeing your face and just outside or at the shops, they're really not going to take a lot of that important information in. So if it did come time to claim, your documentation about what you discussed is going to be really important there. And finally, I think your safety netting advice is going to be really important, especially during telehealth consultations, just so that they have that feeling of security, that you are around if they need you, and that you have equipped them with the right tools, like the red flag signs to be aware of, and what to do after that, whether it's to go to emergency or to call you back or something like that. Because I think that's the main thing in telehealth. It's getting your patient comfortable enough and know that you really are there for them, even if they haven't physically been in touch with you. So that's it from me. I think from all of this, what we know, what we've learned very quickly is that telehealth is certainly much more than just, am I going to use Zoom, or am I going to use, FaceTime, or am I going to use Skype? It's really about embedding a process. And if you have a process that you take your patients through and that your practice staff are aware of for face-to-face consultations, try to mirror that for telehealth, but then pinpoint where those things will be different and what you'll have to do differently in order to make that treatment a success for you and the patient. Thank you.
Thanks very much, Rocky, for the presentation. And there's I'm sure there'll be questions that arise out of that. I'd like to now introduce our third speaker, Bridget Clancey. Bridget's an ears and throat surgeon from Warrnambool in southwestern Victoria, but importantly, she's the chair of the college's Rural Surgery Section Committee and the Diversity and Inclusion Advisor at the Australian Society of Otolaryngology, and also the head and neck surgeons. She's passionate about rural patient-centred care and has an integrated telehealth as part of her practice. So Bridget, thanks very much for filling us in on the rural perspective on telehealth.
Thanks, Mark. I also acknowledge the traditional owners of the land where I live and work, the Peak-Warren and Kern-Copen peoples of the Gunditjmara Maar Nation. As Mark said, I'm a rural generalist ENT surgeon, and we have a VMO model of care in our region, so that all specialist consultations are delivered in private rooms, and the closest public hospital outpatient clinic is 2 hours in one direction and 6 hours in the other. So I've always been keen on telehealth, but it's had a relatively low uptake for my patients, but not anymore. So in March, this article was published outlining the unique risk of COVID-19 for ENT surgeons. Our international colleagues were more likely to contract COVID, had more severe disease and higher mortality. Further to that, even the most basic ENT examinations were found to be aerosol generating. So within 48 hours, my practice transitioned to 100% telehealth. There are pros and cons to telehealth, and we've heard about some of those already. For me personally, you can see on the right-hand side, I'm pretty comfortable and cheerful delivering telehealth consultations in my office or at home. And on the left, I'm wearing level 3 PPE, including an N95 mask. This is what was required for me to have direct contact with patients initially. And I can tell you, and you probably know yourselves, it's hot, it's uncomfortable to breathe, and it costs more than $25 per patient encounter, even if you were lucky enough to be able to support a source for supplies. In the 12 months prior to COVID, less than 1% of our consultations were delivered via telehealth. And I should say that this data is from my practice, and I'm joined in practice by my colleague, Dr. Emily Young. So this data relates to both of our consultations. Since the last 3 months, 75% of consultations were by telehealth, so an enormous increase. Prior to COVID, I had never conducted a new patient encounter by telehealth, but post-COVID, we found that more than a third of our consultations by telehealth were for new patients. We have had 3/4 of new and review consultations occur by telehealth, and the remainder in person with level 3 PPE. 2/3 of those telehealth appointments were by video and 1/3 by phone. And as Rocky said, our preference is for video. I find that my ability to understand the patient and develop rapport is vastly superior by video. So certainly conducting a new patient appointment by phone is a pretty nervous endeavour. We already had the infrastructure and attitude in place to do telehealth, but what was new during the COVID period was the value proposition for patients in that they were able to receive care while maintaining their isolation, and also the value proposition for surgeons where I was able to continue to provide care while avoiding infection. The new Medicare telehealth items, especially for phone consultations, and the Department of Health federally temporarily allowing us to email prescriptions and referrals for radiology and pathology were also really helpful. So the next slide is a bit of a how I do it video, and the sound on this is not great, so I'm going to mute it and talk over it. I prefer to use 2 screens. I use a smartphone to communicate with the patient and my laptop to access the electronic medical record, radiology portals, and our practice website and YouTube channel. Patients have a choice of medium, and we elected not to use a proprietary telehealth software program. Most of them are not optimised for smartphones, and in our patient population, smartphones are always the first choice of device for any healthcare. Most patients chose FaceTime, some chose Zoom or Skype, and we have business subscriptions for both of those. Prior to the consultation, my staff get consent by telephone call, SMS or email to our practice policies, including the privacy policy, fees and digital communication. And that essentially asks, are patients happy to receive information by SMS and email to them about their health? Those processes were already in place. They then indicate on the appointment book the patient's choice of medium, and that's where we put our reason why phone call has been preferred by the patient. So the patient that I'm doing a telehealth consultation with now prefers FaceTime. So I would enter the patient into contacts on my phone, record them as a patient, and then start the call. What I've just done there is reverse the camera so I could show the patient results on the screen, and I can do that for CTs as well. At the start of the consultation, we do a 3-factor ID check, particularly for new patients. We confirm the patient's got the time and privacy for the consult, and then we can welcome any significant others that they have with them at the time. If I need to prescribe, I've been printing the script, scanning it on my phone and emailing it to their preferred pharmacy. We ask which pharmacy they'd like us to send to, and my staff very helpfully prepared an email list for me with about 40 local or regional pharmacies, and that was invaluable. If I need to generate radiology and pathology referrals, I generate the referral within the electronic medical record, and then I print it to PDF and then email from the practice management program. Often I'll include a copy to the patient and include their phone number in the body of the email, and we haven't had any x-rays or any appointments not happen through that process. Toward the end of the consultation, I would enter the billing codes and follow-up instructions for my staff. I've found, though, it's quite efficient to make an appointment with the patient while they're still on the call, which saves my staff making a second contact later. Then we move to an agreed treatment plan. We've always aimed to have our patients exit an appointment with a printed plan in their hand, but over time, a lot of patients had asked us to either SMS it or email it, and so that process for telehealth has been perfect. If I'll print type the treatment plan in the medical record. If it's pretty short, I often just SMS it to the patient and it pings on their phone while they're still with me. But if it's longer, we tend to email it. And I can attach attachments to that email if the patient wants copies of their results, and I can copy other people into the email if the patient asks me to do so. So by the time the call's finished, the patient has a written plan received on their device, and their scripts and referrals have been sent, and my staff have commenced billing. The emails that we sent are sent from our practice management software. They're not sent from my personal email address. Similarly, the SMSs are contained within the medical record, not within my phone. So following the consultation, I'd move on to generating a letter to their GP. And again, I import that treatment plan into a letter template. We use RSD or encrypted email to communicate with our referrers. And that means that our GPs get a letter within minutes of their consultation. And following that, I'm ready for the next patient. I've found that consultations take around about the same amount of time by telehealth. Occasionally with a patient who's a very long-term patient that I'm very familiar with, a phone call or a video call might be quite brief. But in general, patients have required more time, more reassurance, and a little bit more work so that it's not a quicker process. Now, Medicare item numbers, Rocky talked a little bit about this. What was unique for rural patients was that we already had Medicare rural health telehealth codes. So they were for new and review patients. And importantly, the patient was required to live at least 15 kilometres from the surgeon and reside in a rural area of 2 to 5. And you can check a patient's location on the Rural Workforce Locator interactive map, and I've put the web link there for that. The consultation must also be by video. So these were the codes we'd used in the past, and during the COVID period, as you can see in green there on the pie chart, the vast majority of our consultations continue to use those codes. But the new Medicare COVID telehealth codes were very useful for patients who preferred a phone call to video, or patients that lived within 15 kilometres of our rooms. And about at least sort of 40% of our patients do live within 15 kilometres of the rooms. It was also enormously useful for my urban colleagues and their patients who hadn't before had access to telehealth codes. I do note, though, that the new codes attracted a lower Medicare rebate than the existing codes, which significantly affected practice viability. So there are upsides and downsides to telehealth. The upsides for me generally outweighed the downsides in the short term. I particularly enjoyed a perceived strengthening in patients' shared decision-making with me, and I can only put that down to their increased comfort of being in their own environment and with their own things around them, their family around them, that they were able to take my recommendations and really decide whether they fit with their lifestyle and their needs. So that was really rewarding. But telehealth can't be the predominant method of care for my patients in the long term. As an ENT surgeon, I just need to thoroughly examine my patients with an otoscope, an endoscope, a microscope, at least at the initial consultation. So this was a great stopgap measure, and it's going to be a great part of my practice going forward, but it can't be everything. Our policy during the crisis was to bulk bill all encounters. It seemed like the right thing to do with so many people experiencing economic uncertainty, but it's not financially sustainable, and we need to return to our normal billing practices to keep the doors open. It's actually been a great experiment for me in being able to treat people with no regard to out-of-pocket costs, but it's not something that we can continue to do and remain viable. So what's the next phase? As always, I'd like to take the best of the new and combine it with the best of the old. Ideally, we'd have a whole of telehealth solution integrated with our practice management software and optimised for smartphones, and also a financially viable model of specialist medical practice in rural areas. In looking at telehealth software, I'd recommend that you look up HIPAA compliance. It's often something that's referred to, but it's actually an American standard that came out of their Health Insurance Portability and Accountability Act during the Clinton era, and that guides all of the data security and privacy around digital health in the US. So although it doesn't apply to the Australian context and doesn't have an Australian equivalent, a lot of the companies will claim HIPAA compliance as an indicator of their data privacy and security methods. So thank you for your time and attention, and I look forward to your questions in the panel discussion. I'll stop sharing, Mark.
No worries. Thank you very much, Bridget. Again, terrific to get first-hand experience of that, and certainly I'd agree with a lot of the comments. I've had a very substantive telehealth practice during COVID, and a lot of your comments resonated very clearly. So, what I briefly just also wanted to chat about before we actually take some questions is I also just want to share my screen briefly with everybody, and basically just want to talk about our role to try and via RACS to sort of continue our advocacy for telehealth, and this is really something that is really come out of discussions in our Sustainability and Healthcare Working Group, which is effectively a health policy group that works within RACS. So as was previously mentioned, previously telehealth was only accessible really to rural patients, and as Bridget mentioned, it was MBS item number 99. But due to things like the personal protective shortages, complying with self-quarantine and physical distancing policies, there's really been an explosion. And I would agree, I think I've gone from probably 5% of my practice being telehealth to virtually 90 to 95% being telehealth. It's definitely maintained continuity of care, but it's had widespread utility and viability since it's been introduced, especially again, as Bridget mentioned, because of the introduction of these new item numbers. But as mentioned previously, they are going to expire on the 30th of September. So within our group and within RACS, we're very interested in a surgical patient experience survey, and this was something that we're going to be sending out to all RACS members, and both to have a surgeon survey, so basically what you think of it, but also to have a link that you can actually share with your patients so they can actually directly give some feedback in an unidentified way as to what they felt about the experience as well. Anecdotally, patients have embraced it, in many cases preferred telehealth. Some have said, as Bridget said, improved productivity, it's convenient, they don't have to drive, park and sit in a waiting room. It was easy access, but there are some barriers, internet access and also technology literacy. As a urologist, having a lot of elderly patients, not all of them are particularly comfortable trying to actually access the telehealth. And it's certainly one of the reasons why many of them actually preferred phone over video, because they just weren't comfortable actually using the internet. Obviously, there is an opportunity to advocate to try and retain these MBS item numbers, but really at a government level point of view, we need to provide them data rather than what we think just from our position. So we really want some evidence-based advocacy and to collect some qualitative data on patient satisfaction and surgical satisfaction, so that when the government's reviewing the implementation and the use and the impact of telehealth, we actually have some data that we can provide them about the surgical experience. Whilst Greg Hunt has actually mentioned that he's keen for it to continue, really at the moment through the government, they're only really looking this at the GP primary health level. And at the moment, the College of Physicians are beginning to survey their members and have put out a report on that. As the College of Surgeons, we really need to be doing the same to be discussing the surgical experience. And interestingly, none of them have actually looked at the patient experience, but rather only the practitioner's experience. And we believe that they're both very important. We also have an ability to collaborate from an academic point of view. Researchers at John Hunter Hospital and the Hunter Medical Research Institute in Newcastle are very keen to partner with us with this. And as a result, we're hoping that sometime later this month or early July, there will be the surgical and patient survey links sent out to all of our members. And we'd really encourage you all to actually just spend the 2 or 3 minutes each survey will take, and ideally try and share via email the links with your patients so that we can get the patient experience, so that we can advocate on your behalf. And the RAC's research and evaluation committees, including the SNFs, have been able, thankfully, to use their skills to be able to actually go through the literature and have done a scoping review on telehealth experiences around the world. And they've already shown themselves to be very proficient at doing very rapid reviews in this COVID space. Clearly, this also promotes one of our policies at RACS of trying to promote health outcomes. Part of our strategic plan is we want to provide advice on an influence health policy. And I think this is a critical area that we really actually need to be collecting data, having evidence and advocating on behalf of surgeons. I think there's no doubt that it will probably be more benefit in some specialties than other specialties, but certainly from our point of view, it's something that we think it's very important advocacy work that we should be doing on behalf of our members. So I just wanted to briefly mention that, and just wanted to thank everyone for those few minutes. But again, really just to try and highlight for everyone that when those surveys come through, if people can think about doing them and sharing them, and if you can encourage your colleagues to do that as well, that would be very helpful, because obviously the more responders we have and the more patient responses we have, the better the quality of the data. So for the last few minutes of the thing, we've got about 5 minutes or so just for a few questions. Bridget, there was one question for you that do you have patients who don't want a My Health record, and were there any problems or hurdles associated with that in providing telehealth?
We haven't, as a practice, interacted at all with My Health record. We surveyed our patients 2 years ago, and not a single patient wanted us to upload anything or interact. Since that time, I've had 2 patients that asked me if I could upload something to their My Health record. And I said, look, we're not actually interacting with it as a practice at the moment. And they said, that's okay, email it to me and I'll upload it. So in our practice in a rural area, we have 0 interest from patients in My Health record. So it hasn't been a barrier to us at all. All of the communication we do with patients is via our practice management software that has SMS and emailing capabilities. And all of our communication with their referrers is either by mail, snail mail, or by RSD or encrypted email. So that interoperability of practice management programs to transmit data securely is the most important thing for us. That My Health record is not even on the radar, I'm afraid. I wish it was, but patients have no interest in our area in engaging with it.
Oh, terrific. And Rocky, there was also a question for you from our audience. One of the questions was that with such a small percentage of claims arising out of telehealth, does it mean that really telehealth is the way of the future in relation to lessening complaints or claims?
Oh, that's a tricky one. I wish that was the case, but I think that probably, I mean, the small incidence of claims and complaints over the past 3 years is probably more reflective of the low numbers of telehealth that was actually going on. And as I said, I think that this pandemic has been the advent of telehealth that and our quick move to it is something that we've tried to do, you know, probably for the last decade, and this has really launched us all into it. So it's going to be a really interesting time now from here on to see how the claims progress and the reasons behind the claims. You know, we're kind of worried about what's been missed in this time. We all talk about the main thing about telehealth is, well, I don't have a patient in front of them. I'm not able to do a physical examination. Patients, we have good data that patients haven't been going to get the ordinary tests that they would have normally. So what have we missed in this time? And was it only due to coronavirus and people being scared and staying inside and not interacting with healthcare in the way they regularly would? Or is it a downfall of telehealth? And I think, as Bridget, you put it so eloquently, take the best from the new and the best from the old, and then hopefully a combination of those will really help to bring claims and complaints down. Because I think a lot of the claims and complaints that we see at the moment, there's in claims, compensation claims, when a patient tries to sue a doctor, there is some kind of personal injury. But for a lot of the complaints, the regulators, to APRA, to the HCCC and places like that, it's because their expectations haven't been met, not always to do with clinical care, but how long they had to wait, how much they had to pay, how they felt, their time was respected compared to the doctor compared to the doctors and things like that. So if telehealth can help alleviate those kind of issues, I think that we will see a potential for a downsize in complaints, especially.
All right, so actually, Rocky, I was going to just ask, I mean, there were two things, and it was partly about the video and phone issue, because I guess it was a question of the reason, actually having to formally document it. I mean, again, a lot of my patients are elderly. A lot of them, if they were to try and get on video, would literally have to try and get their daughters or sons or grandkids to come in and actually connect them up. And they've actually all sort of said, listen, just call me, because they, so for them, it's actually more of an ordeal to try and do, because they just don't have that technology literacy. So again, the question is, is that a big issue from the medical legal point of view? There's no question, I think, that the video is better. I mean, if you can actually see each other's face, you can develop a better rapport. But I think there are challenges there for some people, especially the elderly, who are not really used to this technology in any useful way. The other comment was, oh, sorry, you go first, Rocky.
Sorry. I think on that point, it's not just the elderly. I have had telehealth consultations in the last few months, and I preferred the telephone because I thought that well, first of all, the GPs weren't even offering it. They just presumed that it would be a telephone consultation. But I thought that for the issue, it was appropriate as well. And the data that is coming out of the Department of Health is that the telephone calls, I think, are 90% of the 12 million telehealth consultations that have been billed, or some extraordinary number like that. So it isn't just the elderly. The department haven't come out with really strong language or obviously made it the law that you have to do a video conference, because the telephone numbers exist. Traditionally, in the telehealth numbers that existed before coronavirus, it was only video conference, so people had to engage in that way. I think because it was such a quick transition, they had to, in order for this to be successful and for people to really take it up, they did need to include the telephone. So I'm not sure if there is some advocacy for us to do around keeping telephone consultations, and whether there should be guidelines around when it is not appropriate. The medical board do have guidelines about telehealth consultations, and they say basically that they reflect the code of conduct that you would ordinarily have to follow. So there isn't a lot by the way of guidelines from the medical board or anything. The Department of Health says that it's preferable to use, and that's why I've just been advising doctors to just a quick note at the end of the record: telephone consultation, no technology literacy, or patient didn't know how to use video conference or something, just to cover yourself and just so you have a note. Because I know at the beginning of this, it was we're all in this together and we're just trying to make sure that everybody's healthy. And I think that was certainly the intent, and that is true. But we are starting to see some of the trickles of Department of Health compliance come through now. Not on that issue, but I think it's just prudent.
Yeah, it's funny that you're saying about how the video can sometimes you get people more set in a proper clinical setting. I had a patient today doing his video telehealth in the aisles of Bunnings, so I suspect that it doesn't quite always work out like that. One quick one for Denny. Denny, just from an e-prescribing point of view, mate, could you just, on behalf of everyone, just to go through the website where we can, just the URL of the website where we can get a bit more information about how to do that moving forwards, because obviously it's going to be a moving feast over the next few months. So
yeah, for sure. And I generally just point people directly to the digitalhealth.gov.au. We've got a big tile that says electronic prescribing there. And if you click on that tile, it takes you to the page, and there's some information on that page, but there's also another link that goes to prescribers or to dispensers. So, you know, we're continually updating that with, like, at the moment, it's very rapidly moving feast at the moment. So we're continually updating that, and I think that would be the best avenue.
terrific. Listen, as it's now 8 o'clock, I want to thank you, all of our speakers, for terrific talks, and thank them for giving up their time, and for all of you for giving up your time tonight also to listen to the webinar. We will be putting the recording on the college website, so it'll be available to watch through the website as well. And I'd also like to just acknowledge that there'll be another telehealth and digital prescribing webinar on Wednesday, the 1st of July at 7 p.m. Also, for the participants that have joined with us tonight, it's important to know that you can claim 1 point per hour in category 3 of your maintenance of knowledge of skills in your CPD. So if you just want to make sure that you do record that and claim an extra hour. This is a challenging year of everyone trying to get CPD, so this is a way of getting an extra hour of taking this on board. So once again, just like to wish everyone a good night. Thank you for your time, and to the speakers, thanks very much for enlightening us on this important topic, which I suspect is going to be around for a while, and possibly the beginning of what future medicine might be looking like. So thank you all very much.
Thanks, Mark. Thanks, Rocky. Thanks, Denny.
See you, everyone.
Good night.